Please welcome, her real name is Kalsoom, but she goes by Sonia Hussain, who's our pharmacist at the University of Washington IBD Clinic. Thank you.
Thank you, Scott. With that being said, So I don't have any disclosures. So I'll begin with a patient case. HK is a 65-year-old female with a history of Crohn's disease, diagnosed in 2008. Her current therapy is infliximab, 10 mg per kg every 8 weeks. Her past regimen was mesalamine, vedolizumab, azathioprine. She had a restaging colonoscopy in December 2008, where the infliximab dose was increased from 5 mg per kg to 10 mg per kg because it showed active inflammation in the ileum and had patchy erythema in the right colon and proximal left colon. And then for the follow-up, when patient followed up in clinic, patient actually had infliximab-induced psoriasis and preferred not to continue the therapy, and the provider at that point recommended switching medication to ustekinumab or Stelara. So just to kind of give a brief overview of what is a specialty pharmacy, a lot of people know what pharmacists do and do at a retail pharmacy setting, but they don't know a lot of what we do in a clinical setting, and let alone if it's a specialty pharmacy. So specialty pharmacy carries a lot of the medications that are very costly and need special storage and handling overall. And then at UW Specialty Pharmacy, we serve our UW patient population, including Harborview patients. So pharmacy team would include pharmacists and technician, would work with providers, nurses, nurse practitioner, physician assistant, and patients, to make sure a patient gets the best result of the drug therapy. And this is kind of like our model of care that we follow at UW. Just to kind of give you a brief, so we have a unique care model at UW because we have the pharmacists, such as me. I work with the clinic providers, again, the nurse practitioner and the nurses and the MA, so that's the clinic team. Then we have the medication assessment team. So we have billing technicians who will initially work on the medication. And then we have program ops specialists who are also technicians, but they do the prior authorization for a biologic or other medication. And then we also provide patient assistance. So we have technicians dedicated just to do patient assistance for the patient who can't afford the medication. And then it goes to our distribution team, where we have pharmacists and technicians who help facilitate that medication order to the patient. So overall, we use Epic at UW, and everything is documented in Epic. So anytime a provider or team member needs to go look at the status of a biologic or a medication, it's all documented, very readily available. We do have quality oversight too, and part of it, which I'll go into a little bit later, where the pharmacists actually do reach out to the patients who do fill their medications with the UW annually to make sure they're compliant with their medication, they're not having any adverse effects, they haven't started a medication that may or may not interact with their medication that they're currently on. So initial step would be the provider would submit a prior authorization to the pharmacy requesting a prior authorization for a biologic. Pharmacy technician team works with the insurance to get the prior authorization and also assist with manufacturer-sponsored coupons or assistance program to reduce the out-of-pocket cost. And this is on top of whatever the primary patient's copay insurance is. You have assistance coupons that will bring the copays down. Then the clinic staff from the clinic will schedule the appointment with the pharmacist, and the pharmacist at that point assures that screening such as tuberculosis testing is negative and laboratory testing are completed prior to starting a biologic. So going back to my patient HK, patient was immune to hepatitis A, was not immune to hepatitis B despite repeat vaccine. So while I'm working on this just patient pre-workup, I had recommended a Haplisaf, which is a neurohepatitis B vaccine, which was approved in November 2017, which contains an adjuvant, which is not in the regular hepatitis B vaccine, to help boost the immune response. And also, data has shown it is 98% or more effective than just the regular hepatitis B vaccine. Tuberculosis test was checked in June 2018, which was negative, but we repeated annually. So my other recommendation would be to repeat it when I meet with the patient. Influenza, recommend annually. Patient was up to date on pneumonia vaccine, and the Shingrix, I was going to recommend it during the visit. Then I evaluate for drug-drug interaction during the pre-workup, and I also send the prescription to the pharmacy when I'm doing this pre-workup. So during the teach visit, I update the medication history. It includes all the over-the-counter medication, other medications patients are taking, just by gathering the medication history with the patient. Review their allergies, update them as needed, and again, review their immunization as listed. And injectable drugs, really educate them on proper injection technique, administration, dosing, frequency, common and serious side effects, drug interactions, storage and disposal, and possibly expectation of drug effect. Oral medication, also dose frequency, missed doses management, side effects, serious side effects, and safety and monitoring. And at last, medication adherence, as we all know, is really important. So monitoring for biologics, after the teach visit, so initially when I meet with the patient will return to clinic if needed for 4-week follow-up with the pharmacist, or sometime I change them to over the phone, depending on the patient. If I feel like the patient needs further monitoring, or may even be helpful just following up with them over the phone, just as a reminder, I do it over the phone. If not, they'll be seen by a provider in clinic in 8 to 12 weeks. Pharmacists can also help assess the response to therapy in 8 to 12 weeks. So if a provider is not available and they want to come in and see a pharmacist just to make sure they're doing well and they're responsive to therapy, that can be scheduled with the pharmacist. Immunomodulators such as azathioprine and methotrexate, I do the initial lab monitoring for 8 to 12 weeks. So once that initial monitoring is completed, then the patient follows up with provider every 3 to 4 months for routine lab monitoring. And if after the 3 to 4 months, if the further adjustments is needed, dose adjustment, pharmacists can also intervene. The last one, I also provide vitamin B12 teaching in clinic, and that's usually just an injection training visit, and after that, subsequent monitorings are with the provider. Ordering medications and labs. So pharmacists can actually assist with sending new prescriptions or refills under our collaborative drug therapy agreement. So I will refill medication, renew all of their biologics as needed. And I just send them to the designated pharmacy, because with biologics, the pharmacy, their patient's insurance will dictate which pharmacy they can go to. So I'll send it to the designated pharmacy. For all other medication, just to help with side effects, if patient complains of severe nausea with the methotrexate, or I will prescribe them a Zofran. I can prescribe them a salamine and prednisone, given it is under the CDTA agreement. And I can also order baseline labs and routine lab monitoring. So overall, pharmacist's role is to improve patients' outcome in IBD population, provide proper injection training technique, and adverse effect management, and information on drug expectation, provide follow-up on treatment efficacy and tolerance, provide information on the necessity of vaccination and smoking cessation, and then clinic counseling around anticipated timelines for improvement, and prescriber follow-up in response to patient symptoms or adverse effects can contribute to the success of a patient's treatment. And also, adherence and monitoring, I think it's a really big component of pharmacy, just the teaching. So just help identify methods to assist patient in adherence and specialty pharmacy care requirements. And as I've said previously, so patients who do fill their medications within the UW, I do reach out to them minimally at least twice a year, just to make sure, again, they're compliant with their drug therapy, they're filling their medication, and they're not having any side effects. So just coming back to my patients, so kind of give you a recap. So the pharmacy technician team got their approval for ustekinumab. The out-of-pocket cost for one pre-filled syringe was $3.80. Patient received the IV infusion on May 28th, and I met with the patient on July 26th. Patient received the Haplasep vaccine and was agreeable to get the Shingrix vaccine when it was available because it was on a shortage. Now we have it available at most pharmacies. And patient was returned to follow up with the provider in clinic in 4 weeks, which is 12 weeks from their infusion. And the next specialty pharmacy outreach will be just in 6 months. So just kind of like in summary, pharmacist's role is to educate, work with healthcare providers and staff, and to ensure medication access. Specialty drugs represent one of the fastest growing sectors of pharmacy spending, with inflammatory disease therapies at the forefront. As pharmacists are accessible healthcare practitioners, their responsibilities should include financial and clinical management with inflammatory diseases who are receiving specialty drugs. I think thank you.
That was wonderful.